Perfect. Okay, so for the final part of our presentation, we will be covering intensive EXRP, which includes 4 phases: the information gathering stage, intensive EXRP, a home visit, and maintenance and relapse prevention. So the information gathering stage includes all parts of the interview that Jack just covered, which includes specifically the patient history, the severity of their OCD symptoms and what their rituals involved, as well as their treatment suitability, which greatly involves their motivation in completing treatment and reducing their OCD symptoms. That covers all of the first information gathering. Typically, information gathering is completed over 4 to 6 hours within 2 to 3 days. In the second day, you go over the treatment rationale, which involves all aspects of the treatment, as well as the identification of a support person that your patient can use. Usually that's a family member or a friend that will be there to make sure that they are doing their homework, they're monitoring their rituals correctly, and that they're recording everything that they do day to day. After that, you generate the treatment plan with the patient, which covers how to monitor rituals, how to record them properly, as well as describing the homework that they will complete every day before the next treatment session. So intensive EXRP typically consists of 15 2-hour treatment sessions that are conducted daily for 3 weeks. So that definitely meets the definition of intensive. Although that is the recommended length, it can have a minimum of 3 per week, depending on the schedule of the therapist and the patient. The evidence greatly suggests that mass sessions provide better results. So as Shanika was talking about earlier, it's better to have prolonged exposures instead of infrequent, shorter periods of exposure. And intensive EXRP is a more pronounced and longer period of EXRP. Typically, each session begins with a 10 to 15 review of the homework and previous day's ritual monitoring, and then the next 90 minutes are split into 45-minute segments of imaginal and in vivo exposure. Imaginal exposure is very important as part of the treatment program and as homework. So within these imaginal exposures, the patient is asked to vividly imagine the antecedents, the actual ritual situation, and the consequences that could come from that. And then those sessions are recorded, and then the patient is asked to listen to those as part of the homework before the next day. And then the next phase of that treatment day is in vivo exposure. That can involve going to an actual place, going to a home, going to the workplace. It all depends on where the ritual takes place for the patient. And then the final 15 minutes are spent discussing the homework for the following day and any concerns the patient has in the treatment program. Of course, this format can be manipulated to suit the unique challenges and needs of the patient, as well as the therapist. If, for instance, the OCD's patient's rituals and fears are aligned with a more unrealistic event, such as their house lighting on fire, obviously you can't go and light their house on fire. So most of that treatment session will be focused on them imagining that and then recording it and exposing themselves over and over to that idea. Whereas if it's something more practical or realistic, the imaginal section can be used as a 45-minute segment or less before in vivo exposure is used. Finally, there's the home visit and maintenance stages. Basically, these stages are used to ensure that the gains used from therapy are generalized to one's home environment, and depending on the patient, also their work environment. This helps give time the therapist and the patient to discuss the guidelines of normal behavior and how they can use all of the techniques they gained in therapy to use in their daily life. The frequency of home visits is usually based on whether the OCD symptoms are transportable to situations outside of the home or whether they're specific to the home. So, like I said, if they're performing rituals at their workplace, you might want to split their time with situations in the home and then taking them to the workplace and exposing them there, and working to provide more exposures if needed. Usually these home visits are 4-hour sessions that are held over the 2 days at the end of the treatment program. But if maintenance is needed, more sessions can be included. Usually these are used to have additional exposures. And although a lot of patients don't need the additional exposures, depending on the severity, patients may need more time. Finally, when deciding to use intensive EXRP, a therapist should take into account the variables of themselves and the patient. Usually, I think as Jack and Shanika, I'm so sorry, described earlier in the presentation, it usually requires a balance between empathizing with the patient and pressuring the patient to engage in the treatment, because it can be very distressing and stressful for the patient to really over and over again expose themselves to their fears and their rituals. So usually therapists who are respectful, understanding, encouraging, as well as explicit and challenging are more successful than permissive and tolerant therapists. So the therapist really needs to look at themselves and their treatment method as to whether they would be a good fit for providing this type of treatment. It really requires the ability to know when to push, when to confront, and when to be more flexible. And as much as possible, the therapist should display an attitude that counteracts the harshness of the treatment program while maintaining the rules established at the beginning of the treatment program. So for these sort of things, since it's so intense, if the patient is really showing a great deal of distress, the therapist should take the time to really get to know the patient and make them feel like they are in a secure environment where someone is really there and they're caring for them. In terms of patient variables, the primary factor is the level of motivation, as I mentioned in the beginning of this segment. Since it's really intensive and very distressing, as I mentioned earlier, a patient really needs to be highly motivated to undertake this treatment. Usually motivation is affected by the severity of symptoms. So those with greater severity and symptoms are generally more tolerant of intensive EXRP, and they're generally more motivated to complete treatment. Generally, patients are less likely to follow directions if they're driven to therapy by family members. So if they're really being pushed into this type of treatment program, the therapist should really think about recommending an alternative treatment for them. And then finally, comorbid disorders such as severe depression, personality disorders, and schizophrenia are not good candidates for this type of program and should be recommended for alternative treatment. And that's it. So thanks for listening, guys. We really appreciate it.